So my name is Dr. Carl Lambert. I am a family physician at Rush University Medical Center in Chicago. And also I'm an assistant professor of family medicine in their medical college. So I also direct our family medicine leadership program in the medical school. So I knew pretty early on that I wanted to be a doctor of some kind, oldest of three boys, and I have two younger brothers with autism. So a lot of doctor's visits, a lot of extra needs that they had. So went to a lot of doctor's visits with my parents, and I really just liked how they communicated with our family. It was more than just like a diagnosis, but really it was, they really wanted to learn our story. They wanted to understand our needs and the context of the care that we needed, right? So I was blessed to have two working parents in the home, and that helped. And just from those interactions with doctors and getting to ask questions, and just hearing how they do what they do, that kind of sparked an interest in me to do something similar. So I liked the human body. I liked educating patients or just people in general. I liked the challenge, and most of all, I liked the long-term relationships that you could build. So as I went through, college and med school, I was able to have mentors, a lot of which were in primary care. So as a family physician, and that's under the realm of primary care, I am a regular point of contact. So I'm usually the doctor when patients ask, who is your doctor? They usually will be referring to their primary care doctor. We're their home base. We play many different roles. So, probably most noteworthy for me is really educator, and then also a bit of a translator. Before I was at Rush, I worked at a community health center in southwest suburbs, where we know there was a lot of patients that were having barriers, a lot of social determinants of health. So it was really hard for them to get to specialists. So when they would get to specialists, it's really common for me to get a note from the specialist or a progress note. And then I would ask the patient, hey, what did you all discuss? And the patient will say, I have no idea. Can you tell me what the specialist means? That's really common. So I'm very comfortable with being that translator. Like, well, okay, here's what the cardiologist meant. Here's the medicine that they started. Here's why they started. Here's how long we probably will have you on it. Or here's the test they ordered, and here's why. And here's why Dr. Lambert agrees with that. Or here's why I sent you there in the first place. So, you play that role of really breaking down the specifics of healthcare plans, whether it's myself or if it's a specialist that I've referred to. So again, that the patient understands, like, it's their health. So I want them to be able to understand first and foremost what's going on with them, and that they don't feel out of the loop. You never want your patient to feel like they're out of the loop or overwhelmed with the care that they're providing. So as a primary care doctor, I'm able to really intervene. Usually I am the first person to notice, or me or my staff or even my medical students who are able to notice if there might be a challenge with health literacy, or if we really need to reinforce or engage further with patient education, or even just do teach back with the patient about, like, what is the plan that we made today? Like, what are we going to do, or when are we going to follow up? So, you're able to really implement a lot of those strategies. So again, that the patient feels comfortable, and again, is not out of the loop with the plan that we're trying to make to help them. So I do have some patients that will have a really life altering or just a new diagnosis. It could be cancer, or it could even be something chronic like type 2 diabetes. So some patients really get into it. They will look on Google, they'll look on blogs or just different posts. I mean, we are in a time now where information is really at the tips of our fingers, right? My job is really to tell patients, hey, whatever you're getting, bring that to me so that we can make sense and contextualize it to you. Because sometimes too much information can be a dangerous thing if we don't apply it in the right way to an individual patient, right? So some patients will absolutely dive in. They'll ask me questions. We have patient portals now, so patients can actually send me my chart messages, which are almost like emails or like instant messaging about just different things. If there's an article, or they just had a question or something that was on their mind, and we can interface that way. So that's one way to really break down barriers, as opposed to having to wait for appointments with me every 3 to 6 months. So we can be in communication that way. And then I do have patients that are more comfortable with me leading the charge. They say, hey, Dr. Lambert, you're my go-to guy. I trust you. Just make sure that you do right by me. And I'm comfortable taking the reins. But I think it's a dance, right? So, whatever's most comfortable. And that may change, that may shift. Like, with patients with certain diseases and we have it well controlled, they're much more knowledgeable and comfortable after a year or two. And then there are some patients that, again, they really just want me to make sure that I'm meeting with them regularly and making sure that we're, crossing T's and dotting I's. And that's totally okay. Whatever is comfortable with the patient, and most certainly never inserting shame or disdain for whatever choices they choose to make. I think we do need to make sure that we give our patients credit for showing up, because it's really daunting. It's daunting. There's a lot of, full transparency. So I'm a new dad, have an 8-month-old son who's had a prolonged hospitalization. And even for me as a physician, sometimes that's difficult to navigate his care. So I can only imagine how difficult it can be for some patients with insurance or without insurance to even get to the doctor. And not just that, but getting your medicines or making appointments with specialists or having to get tests like colonoscopies and mammographies. That's not an easy thing, So I think we need to honor that, and then again, not make assumptions, and then normalize the language that we have. And again, as a family doctor, since I'm a consistent point of contact, or I'm the place where patients really, they probably will feel the safest, I can engage in those conversations in a, again, a non-confrontational and a safe way to just check in to say, hey, how are you feeling about the plan? Do you understand the plan? If not, this is a chance for us to talk about it. Visits often in our office they'll kind of naturally allow those conversations to happen, so patients don't feel like we have judgment towards them, but really just, again, a safe space. So if you truly understand, you're 100% with me, we're good. But if not, I want to know, on the front end as opposed to the back end, because again, it can become even a safety issue if we know patients aren't taking medicines or not doing things because they don't understand, or they were just too afraid to ask. So we want to break down that barrier too. So again, communication is key. You can figure out, well, what sort of interface works best with a patient. Sometimes that's really verbal. So it may be me, or I may have a medical student at the end of our encounter. I'll say, hey, talk to Mr. or Miss So-and-so a little bit more about diabetes and nutrition, or hypertension and the DASH diet, right? So some patients having that extra time and actually talking and having a conversation where you can even quiz them, like, hey, what did I just say? Or how many milligrams of sodium should you eat a day? That helps it to stick. And then I have some patients where in the middle of a office visit, I have to draw kind of like this, like I'll draw the heart or I'll draw, the procedure that they're going to have. Like if they're going to have gallbladder surgery, I'll draw a little bit of the GI tract and explain to them, like, this is what's happening. Here's why, here's what it does. And, some patients are very visual learners. So, and then also I think another piece that we can do is that we can help connect patients to just different interfaces that they can use in between office visits. So, again, like you mentioned, there's apps. We have, patient care navigators. We have health advocacy. We have social workers who really can help to identify, we identify those needs, and then the rest of the team can really help us to get those resources to patients. So thankfully, it's not just me, but I employ my team. So that could be the student, that could be our front desk staff, that could be the medical assistant. Really, it's a whole team effort to really get the information to the patient and packaged in a way that they really would appreciate. So you ask, you can ask, like, what would you prefer? Do you want one method, or do you want a variety of them, right? Before you have them leave. And then again, you always keep the door open. So if you have further questions, or if you're overwhelmed, you can always reach out to us and we can troubleshoot it and talk a little bit more. But, the last thing I want a patient to do is have questions and be too afraid to tell me. So I always try to do my best to create a safe space and let them know, like, I'm here as an advocate. This is a part of what I do, right? So I want you to feel empowered and knowledgeable about everything that's going on with you.